Hi everybody, my name is Nicola Maurizzi. I'm a cardiologist from Lausanne University Hospital in Switzerland, and I'm very happy to be here for the 7th episode of HCM Pills. We are here with Juan Pablo Kaski, who's Professor of Pediatric and Hereditary Cardiology at the UCL in London and a world-leading expert in pediatric cardiomyopathies. So I just want to remember that these series of webcasts have been sponsored by the European HCM Patient Foundation, who is a non-profit organization aimed to improve disease awareness all over Europe about HCM. So Juan Pablo, thank you very much for being here. It's an absolute pleasure. The first question is, can HCM be diagnosed during childhood?
Thank you very much. It's a pleasure to be here and delighted to be talking to you. So hypertrophic cardiomyopathy actually is a condition that can present at any age. We certainly diagnose hypertrophic cardiomyopathy in childhood. We sometimes even diagnose it before the baby's born, so antenatally, but that's very, very rare. And I think one of the things that we are understanding is that there are certain types of hypertrophic cardiomyopathy that most frequently present in very, very early stages, so in very young babies, newborn babies, or the first year of life. And those are usually different causes to the things that most commonly cause hypertrophic cardiomyopathy in adults. So as you know, the most common cause of hypertrophic cardiomyopathy are mutations or changes in particular genes that we call sarcomeric genes. So those are the genes that are important for how the heart muscle itself develops. Those are also the most common causes of hypertrophic cardiomyopathy in children, particularly after the age of about 1 or 2. But in that first year of life, there are other things that can cause hypertrophic cardiomyopathy. So conditions that can affect other parts of the body, not just the heart, so syndromes like Noonan syndrome or metabolic conditions that again can affect other organs within the body as well as the heart. But yes, in answer to your question, we pick this up at any age, and it's actually really important for clinicians and for pediatricians to be aware of the possibility that hypertrophic cardiomyopathy is one of those conditions that they need to think about in small children.
So diagnosis of HCM during childhood, what are the implications? What are the implications for the management, and what are the implications also for the pediatric cardiologist?
So that's a great question. So I think there's a number of different things to think about. So first of all, actually, something that's really important is that when we diagnose a child with hypertrophic cardiomyopathy, it's important to look for the cause. As I mentioned, there are lots of different things that can cause that. But that's important because the implications of the underlying cause are significant. So we know that, for example, some of those rare metabolic or syndromic causes that present in that first year of life, they tend to be associated with a different disease cause, a different natural history. But also there are specific treatments for many of those conditions, so enzyme replacement therapy for some of these metabolic conditions. But thinking about the sort of more common causes of hypertrophic cardiomyopathy, increasingly we're picking these patients up as a result of family screening. And there's this idea that if you have an early diagnosis of hypertrophic cardiomyopathy, that must mean that you have more severe disease, that it must mean that you're at risk of disease-related complications at an earlier stage, and that's not actually the case. So I think there are certain patients that we pick up very early on who have a lot of symptoms, who are very sick, and it's very important to look after those patients very carefully. But just having a diagnosis in childhood doesn't necessarily mean that the condition will be worse or that the risk of complications is going to be highest. It does mean that we need to keep a close eye on things. It does mean that we need to monitor things very carefully. But knowing that the condition is there allows us to really keep a close eye, to treat when we need to treat and to prevent disease-related complications. I guess another implication is for the patient and for the family themselves. And so I think something that's very important for pediatric cardiologists is to be aware that when we're dealing or treating a patient with hypertrophic cardiomyopathy, it's not just the patient that we're treating, it is the whole family. And I think that applies from a medical point of view, but also from a psychological point of view, from a social point of view. So one of the things that we're always super keen to do is that when we make a diagnosis, actually everything that we do is so that that child, that individual, can live as normal a life as possible. So that requires multidisciplinary approach. It requires having psychological input, it requires the expertise of genetic nurses, etc. But that idea of the family and living a full life is central to how we identify and treat patients with hypertrophic cardiomyopathy in childhood.
And this is extremely relevant, specifically if you're dealing with children who have to develop in a normal way and live a normal life. So we do know quite a lot of things about, how to identify patient at risk with hypertrophic cardiomyopathy, how to treat obstruction with septal reduction treatments, myectomy, alcohol septal ablation, how to prevent sudden cardiac death by implanting ICDs, all those things that we know for classic, I would say, hypertrophic cardiomyopathy do translate also for pediatric diagnosis of HCM?
That's a really interesting question, because I think for many, many years, the management of childhood hypertrophic cardiomyopathy was almost exclusively extrapolated from adult data. But I think one of the things that has really changed in the last 5-10 years has been that we have seen an explosion of expertise and experience and data specifically on childhood hypertrophic cardiomyopathy. And so that means that actually when we're treating children with this condition, we can now say that we're doing this on the basis of pediatric data. And a lot of the ways that we treat childhood or adolescent hypertrophic cardiomyopathy is actually very similar to adults. But there are some differences, and so it's really important to bear those in mind. So, for example, one of the things that we sort of focus on is identifying children who might be at risk of abnormal heart rhythms and collapse in later life. For many years, we were using an adult approach. And actually we showed that doesn't really work so well in children, that there are very specific potential risk factors that we need to think about in children. And so, one of the things that we've done is develop this risk prediction model that is pediatric specific. So it takes information from the clinic based on pediatric data, and it allows us to estimate the risk of an abnormal heart rhythm over a 5-year period. And then we can use that in our discussions with patients and with their parents. So a lot of it is sort of borrowed from adult practice, but it is pediatric specific, and I think that's really, really important.
Yeah, that's super important. We are not dressing our children with ties and blazers. That's very important because, one size doesn't fit all.
Correct, and children are not small adults. And I think that's a really important thing to remember.
It's a key point. But, we're been discussing about families. Families are central in our job, dealing with inherited cardiac disorder. And let's make, a different case. I have myself hypertrophic cardiomyopathy. I'm in my 40s, I'm in my 50s. When shall I test my children for hypertrophic cardiomyopathy? Shall it be really very early in life because of the fear of pediatric cardiomyopathy, or shall it be later really to have a shared decision making whether to test or not to test? It's a difficult.
So that's a fantastic question, and again something that I think our knowledge and our understanding and our recommendations really have changed significantly over the last few years. So in the past there was this idea that we shouldn't be testing children younger than 10 or 12, and that was partly based on this idea that it was very unusual for the disease to develop in young children, but also this idea that children should have a say in whether they want to know. Our knowledge has changed. So we know now that children can present with familial hypertrophic cardiomyopathy. 10, 15, 20% of the time when we screen children under the age of 10, we identify the disease. So the disease is there, and making a diagnosis makes a difference to treatment. So over 30% of the time it changes how we treat that child. So there's no question that in the context of a family history of hypertrophic cardiomyopathy, children can be affected at a young age. So we would certainly recommend clinical screening actually from birth. And that's reflected in the new guidelines. I think genetic testing, predictive genetic testing, so if we identify a gene that is responsible for the disease in the family that allows us to do a predictive genetic test in a child, again, there was this idea that it shouldn't even be offered to young children. That has changed. We know that from speaking to patients, from speaking to children and teenagers, we know that teenagers often want to know. They want to be involved in those conversations, but they want to know the answer. And so it is part of a shared decision making. There are lots and lots of things to take into account, to consider. So genetic counseling is crucial in this context. in the 2023 guidelines, we have a big table of the issues that need to be discussed in the context of genetic counselling. But our practice is that we would offer genetic testing and clinical screening at any age. That doesn't mean the families will necessarily want to take it up at that point, but that offer of genetic testing should be made to all families, I think, regardless of age.
I think those are very important key messages, not only for our patient, but also for practicing physicians all over Europe, and has to be really been stuck in your mind and have these in your practice. I'd like to finish with a provocative one. In medicine, we always have this feeling that the earlier, the better. So the earlier we treat a disease, the better will be the outcome. So with the advent of this really disease-specific modifier treatment, and that is the inhibition of the modulation of the myosin, the mavacamten and the aficamten. Do you have experience in the pediatric cohort? Are there any studies going on? And what's your vision about when shall we start those drugs?
So that's a fantastic question, and actually a really exciting time, because it is, as you know, the first time that we have drugs that have essentially been designed to treat the condition. And what's really exciting is that we are on the brink of having pediatric clinical trials. So there are clinical trials for mavacamten and for aficamten, initially for children with symptomatic obstruction, so very similar to the adult indications, and they're already open. They've already started. They're recruiting patients, screening patients. So I think we will have pediatric data very soon, and there's no reason to believe that they will be any less effective in the pediatric population. In fact, I wouldn't be surprised if we find that myosin inhibitors are just as effective, if not more, in the pediatric population. I think what we will still need to wait a little bit longer for, but the promise really is there, is whether these drugs, if started early enough, whether they're capable of modulating the disease, potentially even preventing the phenotype from developing in the first place in children who are gene carriers. And I think there are some exciting preclinical data for that, but we have to wait and see what the clinical data show. But it's an extremely exciting time.
Couldn't agree more, and unfortunately we have to close. I would say all the afternoon discussing with Juan Pablo about this exciting field that is pediatric cardiomyopathies and their implication. And I thank you very much for following us. Remember to subscribe to our channels and to comment for the question that will be most important for you and that you like to ask to our experts. Thank you very much.